Okay. I do not speak Norwegian, so I will present in English. I hope that is not a problem. So my name is Erwin Hans. I'm a professor from the University of Twente in the Netherlands. And that's, I'm from the eastern part of the Netherlands. That's the part of the country that is above the sea level. That's why I'm not so tall as most Dutch people. It's not necessary. So my background is in mathematics. I did a PhD in production planning and process optimization in manufacturing environments. But since 2003, I've been doing research entirely in hospitals, mostly in healthcare. So optimizing processes in hospitals. I founded a research center at the University of Twente called Choir. And this year, Choir, we also started a spin-off company in which we develop software, but mostly we do consulting for hospitals who want to try to improve the efficiency of their processes and to redesign their planning and control. Our research center is called Choir, Center for Healthcare Operations Improvement and Research, has as a mission to help healthcare organizations to improve their productivity, so their efficiency, but at the same time improve the quality of care and the quality of labor. So we want to try to organize the processes in such a way it becomes more pleasurable for the people to work in healthcare. So less running and standing still, less overtime, so working smarter and not harder necessarily. But at the same time improving quality of care and efficiency. And of course we do that with a scientific approach. We're researchers, and like the previous speaker, we use quantitative techniques and ICT, so computer simulation, mathematical modeling and optimization techniques to prospectively analyze different ways of organizing processes, a different way of planning, so that we can objectively recommend hospitals how to improve their processes, where at present hospitals are very much subjectively choosing for the ways to organize the processes. We do this together with the care providers, more than 15 hospitals we collaborate with throughout the country. So these red dots are different types of hospitals, academic centers, top clinical, general, peripheral hospitals, and specialized clinics, also rehabilitation centers. And what we do is, so we have PhD students, master students, and bachelor students doing projects in these hospitals. And my PhD students, there are 7 at present, they have an appointment at the hospital. They are at the hospital for 3 to 4 days a week. And at this hospital, they are the to-go guy or girl for the logistical problems. So the people from the hospital approach them with, so we have problems in our department with patients waiting and complaining, or we're running and standing still. One day it's too busy and the other day it's very relaxed. So can you help us with that? So my students, they gather these questions and we do our research entirely based on these questions coming from practice. So these PhD students do this research, but I also supervise master and bachelor students. I supervise more than 200 projects in hospitals, dealing with all the departments you can imagine, and increasingly also dealing with optimizing the entire care pathway. So we mostly do research. We also teach healthcare managers in the basic principles of operations management. And as said before, shortly we also have a spin-off. So hospitals approach us and ask us, so how can we integrally optimize our hospital? And where are we standing at this point? How far are we with this? And there are 2 complementary things that should take place in hospitals. That's a bottom-up optimization and a top-down optimization. So with the bottom-up optimization, I mean that a program like, for example, Lean Six Sigma, but there are many others like logistical paradigms, focusing on maximizing value and minimizing variability and minimizing complexity and control. Basically organizing that the culture exists in a hospital where everybody is trying to improve the processes continuously. So a culture of continuous improvement. Increasingly in the hospitals in the Netherlands, you see whiteboards in the corridors where the nurses make remarks about the problems that they encountered during the day. And once a week, these problems are discussed within a group and then dealt with. So everybody is continuously focused on improving conditions. Similar, of course, to what you see with the lean concept, the Toyota manufacturing system with the Toyota production company in Japan. This also generates a lot of data that we can use for analyzing and optimizing also the planning. People focused on improving performance, they also have to think about what is performance. So with this bottom-up optimization, people in hospitals start thinking about what are the performance indicators that we actually want to optimize. And in many situations, when I first speak with managers, they say they have problems, but they cannot express it in numbers. They only have a subjective idea of what is the performance. So this is not my business, but it is very important and it's very complementary to what we do. But there are many consulting firms in the Netherlands that focus on Lean, Six Sigma, TOC, BPR, TQM, TOC, Total Access, and many of such kinds of programs. So my research is focused on the top-down optimization. So the design and optimization of the integral planning and control of the processes. And I'm going to explain that a little bit more. What do I mean with integral planning and control? Well, integrality means optimizing the entire care pathway, because that is the product that basically the patient receives. And the hospitals, at least in the Netherlands, but I'm sure it's not much different here, the departments are organized as single cost centers, so they optimize within the department. And they don't care so much what happens downstream or upstream with the patient. So you see local optimization and not the optimization of the entire care pathway. So integral planning is about optimizing the entire care pathway. It's also about optimizing all the managerial areas together and all the hierarchical levels of control. And I can illustrate this nicely with this planning and control framework that we published, where you see 4 managerial areas. So medical planning is the clinical decision-making by doctors and nurses. So a patient arrives and you decide on a care pathway of that patient. That's a doctor that makes such kind of decision, but that's important information that you use for planning. It's also important information that you use for ordering materials, for example, and it also gives you a lot of financial information. So medical planning is all the clinical decision. How urgent is a patient, for example? What is the expected duration of a procedure? These are estimates made by clinicians, for example. Also, are we going to locally anesthetize the patient or entirely anesthetize the patient? These are all medical decisions. My research is mostly about the planning of the renewable resources, planning of staff, planning of equipment, planning of rooms, operating rooms, for example. Then there's the managerial area of materials planning, the non-renewable resources or the disposables, and of course financial planning. In the end, it's all about money, right? So integrally optimizing means bringing these managerial areas together and coordinate them in an optimal way. Hierarchically, there's the traditional strategic, tactical, and operational planning where we make a distinction between offline and online. So offline is the short-term in advanced planning. And in the short term, demand is entirely known. So the elective demand is known. And supply, so your capacity is inflexible. So the only thing you can do is basically shift activities in time. At a strategic level, at a very high level, and very long-term level, this is where the vision and mission strategy of a hospital is translated into resources and processes. So entirely based on forecasts, long-term forecasts, where supply, so your capacity is entirely flexible. You can still decide on how many resources to organize. And at the operational online level, that is the monitoring and control of the process while it happens. So this is basically where it happens. And your flexibility is only to postpone things and to cancel things. Now, in the middle of this is the intermediate term, the tactical planning level. I explained this last because this is the most underexposed level of control. At the intermediate term, demand is partly known. You've already made some appointments on the intermediate term, but for a part also you need to forecast it. And supply, importantly, is partly flexible. And in the intermediate term, you can organize to temporarily have some additional capacity, or to organize your people to work in overtime, or to get some temporary staff, for example. And this flexibility you can use to soften the effects of variability in the intermediate term. But in the hospitals where we do the research, seldomly active planning is done at this tactical level. And I will give some examples of that. And by not actively planning and by not using this flexibility, typically you see managers being busy with trying to solve the problems on an operational level, extinguishing fires, firefighting all the time. And if they cannot solve these problems, then the universal answer for all the logistical problems is more capacity. We have problems already for 5 years, now we need more capacity. And this is a strategic decision. But without thinking about how to allocate this additional capacity, you're basically creating a bigger mess, right? And I've never seen an example in my research where a department did not have enough capacity, right? There's usually plenty capacity, but it's not organized properly. So the tactical lever is very much underexposed. It is very complex because, well, operational level, this is here and now, and the short term, you can imagine what's happening. In intermediate term, you're basically forecasting a part of what you still have to do, and it's more vague, it's more abstract, and perhaps this is one of the reasons why it is underexposed. But also at a tactical level, you look not only at a longer planning horizon, but you also look at a bigger part of the care pathway. And we try to integrally optimize outpatient clinic, operating rooms, the ED, and the clinics. And in our research, we've looked at all kinds of aspects of this care chain. So the case mix composition, the roster of the outpatient clinic, operating room scheduling, and things like, do you need emergency operating rooms or not? And how many emergency teams do you need during the night? Or how should you schedule the surgeries to minimize overtime, for example? Pooling of, so putting together departments, awards, what is the effect of that? So all kinds of topics we've looked at in our research. But the coordination of such a chain is very complex, and if you optimize each part individually, this leads to all kinds of variation downstream. So bullwhip effect like you have in supply chains. So capacity management is in fact variability management. And there's an apparent contradicting goals that can be reached through variability reduction. I will demonstrate this. So what management typically is focused on is maximizing utilization. So we have expensive resources, and so we have to utilize them, right? So maximizing utilization. Personnel, in the Netherlands at least, they want to go home at 5, and when they work for 8 hours a day, then they want to have 8 hours of work, and not today 4 hours and tomorrow 12 hours. So they want to have a stable workload, so minimize overtime. And patients, well, in addition to proper quality of care, they want to minimize the access time and the waiting time in the hospital. Now there's an exponential relation between utilization, workload, and waiting time. Right? If you go to the supermarket and the utilization is 90%, then your waiting time is 10 times the service time at the cash register. If the utilization increases to 99%, the expected waiting time is already 100 times your time at the cash register. So if you maximize utilization without reducing the variability, you're basically maximizing waiting. So focusing on maximizing utilization maximizes also waiting time and also maximizes overtime. So typically in all the projects I do, you see that demand over time, the highest peak in the last 15 years is typically what is the capacity of the department. So by maximizing utilization, you're pushing up this wavy line and basically maximizing overtime and maximizing waiting. However, if you focus on minimizing variability, if you manage to level this out, you can lower the ceiling of the capacity. And at the same time, you maximize utilization, you minimize the waiting, and you minimize the overtime. So it's far more important to minimize variability than to maximize utilization. Okay? Now let's look at some of the research we did. So the relation between outpatient clinic and operating rooms. This is a very important relation. The doctors basically work in an outpatient clinic or in the operating rooms. This is where they see new patients from the waiting lists. Then after they see the patients in an outpatient clinic, they wait for surgery, they have surgery, and then they go to a ward and basically go home. And after surgery, patients will have to come back for a revisit to the outpatient clinic and maybe for some follow-up procedures. A very simple representation of reality. So what happens is that, of course, the arrival of patients fluctuates over time. in wintertime, patients fall down because there's ice on the street and they break a hip, so you have more orthopedic procedures, for example. When the weather gets nice, you have more lung patients. So you have fluctuation in demand. At the same time, you also have fluctuations in capacity. So the availability of the doctors changes over time because of vacations and illness and conference visits. And typically, emergency conference visits. Oh, by the way, I'm going to a conference next week. Here you have my operating room. And in that time, you cannot fill that capacity. So hospitals try to organize try to manage this variability by working more in the operating rooms or working more in the outpatient clinic, so shifting capacity from here to there. But what happens is the following. So suppose you increase the effort in the operating rooms. So you take care of the patients in the waiting list for the operating room. But you're working less in the outpatient clinic because the doctors work more here, so they work less here. So these waiting lists are growing extra fast because you're working less here. This is growing. And also the revisit patient amount is increasing. So by working a bit more in the operating room, these waiting lists increase very quickly. So you get a sort of oversteer. And then this waiting list dries out, and basically your operating room dries out because you don't have patients anymore to operate. Alternatively, if you increase working in the outpatient clinic, you take care of the waiting list and maybe the revisit patients, but basically you generate a big waiting list for the operating room. So the question is, how do you manage this? Well, one of the solutions is implemented by a hospital in our region, and there's a hospital we collaborate with in our research. It's a very straightforward solution. So every 3 weeks, the heads of the surgical departments, they have a meeting that's called a tactical planning meeting. And in this tactical planning meeting, they look back a couple of weeks to the recent utilizations of every surgical specialty in the outpatient clinic and in the operating rooms. They also look at the current production and the production agreements. And they look at prospectively at the coming weeks. So what is expected in the coming period? So is it going to snow and more people will break hips, so we need more orthopedic surgery, for example? Then we know this. Our doctors are going to a conference of orthopedics, so orthopedics will need less surgery time. So a part of the operating room capacity, some 20% of this operating room capacity, some 20% of the outpatient clinic capacity is based on this meeting. It is reallocated to the specialty that needs it at that moment. So specialties that have a really long waiting list at the moment, or that expect more work in the short term, or that have less capacity in the next term, they are either given capacity or this capacity is taken away. So it's a very straightforward principle. But it required 5 years, nearly 5 years to implement. It required a lot of convincing to the doctors that if they give away their operating room time, that they will actually get it back when they need it. And this is the kind of attitude that we encountered. You know, you can touch my wife, you cannot touch my operating room time. But this by now has changed. The doctors are really convinced that all the involved stakeholders in the process actually profited from this approach. What was implemented was a dashboard system where all this information that I previously mentioned, the recent utilizations, the waiting list, the production volumes and whatnot, can be displayed in this 3-weekly meeting. And based on this dashboard, these decisions that are then made. And this is one of the most efficient hospitals in the Netherlands. Now let's look at the relation between operating rooms and clinic. In the Netherlands Cancer Institute in Amsterdam, they had an additional operating room. They went from 5 to 6 operating rooms, and the question to us was, so how many more beds do we need if we get another 6th operating room? We translated this question into, okay, so you have a bunch of operating rooms from Monday to Friday, and you have assigned these operating rooms to specialties, so a certain doctor, another doctor, etc. What is then the expected inflow into the subsequent wards based on this so-called master surgery schedule? So what we did is we developed a mathematical model to predict the inflow into the wards based on such a block schedule of operating rooms. In most hospitals in the Netherlands, if you look 10 years ago to the master schedule and you compare it with today, plus or minus 1 is exactly the same. So this block schedule is historically developed, somehow came to be, but is not subject to changes over time. But if you, based on a statistical model, we can calculate what is the inflow into the wards. So this dark blue line was the initial inflow into the wards in the current situation with 5 operating rooms. And you see that in the 2-week planning cycle, on Thursday, Fridays, you have a peak in the bed occupation. So knowing this, what you can do, of course, is you can shift around the blocks to try to level out the inflow into the wards. Okay, so we looked at the combinations of blocks that if we would swap them around, that would make the biggest impact on reducing this peak. So we implemented 3 or 4 of those changes, and additionally we added the 6th operating room. So this line here is the line after this optimization and after adding a 6th operating room. So actually we need fewer beds with an additional 6th operating room. And this model has been developed into dashboard software. It has been implemented at several hospitals. And typically you see reduction in peak bed usage of 10 to 15%. It's a very powerful concept. Other topics we looked at, for example, is the integral optimization of appointment schedules. So, for example, in rehabilitation treatments, you have patients that have to visit different therapists and specialists, sometimes many times per week. And what you typically see, that some of these patients go to the hospitals 5 days a week. And why is that? Because the agendas of all these therapists and specialists, they are not aligned with each other. They're optimized for themselves, but not for the patient. So as a first step, what we did is align the availability, so these colored blocks of the therapists and specialists. And second, we developed an algorithm to generate alternative solutions for the patients that they can select, where we try to optimize the number of times they go to the hospital. So here you see, for example, on Monday, these 3 appointments take place with 3 different specialists. So the patient has to go to the hospital on Monday for 3 appointments, and then on Wednesday for 1, 2, 3, and 4 appointments. So the patient has 7 appointments, but only needs to go to the hospital twice. Right? And if the patient says, no, but I have other activities on Wednesday, then you generate an alternative solution where the patient also has to go twice to the hospital, but now it is on Tuesday and Thursday. Or another solution, or another. So whatever the patient would like. So there's an interface shown at the desk to the patient where the patient can basically select the appointment scheme he wants. So planning, these type of problems are really mathematically extremely complex. And hospital people always ask me, so we want to have an optimal solution. Well, to have an optimal solution mathematically means that you have to evaluate all possible solutions. And then the best solution you encounter is the optimal solution. So just to give you a feel for what is optimal. So if you have 100 surgeries and you want to assign them over 10 operating rooms, any ideas how many possible solutions there are? Can somebody make a guess? Who says more than 1 million? 3? More than 1 billion even? Yeah? Okay, so this is the number. Right? That's a crazy big number. If you have a very fast computer that can analyze 1 million solutions per second, it takes more than 1,000 years to look at all the solutions. And this is just fairly straightforward, you know, small operating room, 100 surgeries, 10 operating rooms, that's not even big, right? But the patients, and we have died, you know, by that time, then we have the optimal solution. So you can forget about optimal solutions. So what we develop is mathematical heuristics, and these are approaches that try to find a really good solution in little time. And we use the speed of the computer to analyze alternative solutions, like millions of them, in a few seconds, and by this we can very quickly find very good solutions. So this is the idea, the mathematical idea behind the planning algorithms. But optimality is very far-fetched. don't believe anybody who tells you that you will get an optimal solution. Capacity management is in fact variability management, as I said before. So to select a proper planning approach for your situation, it's very important to first look at what kind of variability you have. And what we typically do is we look at short-term variability and long-term variability. Let me explain this based on this graph. So long-term variability, I mean, to what extent can you predict what happens with a patient in the care pathway? Okay, with a hip surgery or cataract surgery, you know basically the steps of the care pathway in advance. So you can plan it also in advance. But in cancer treatment, after every step, you have to rethink, so what is going to be the next step? Okay, so there's more variability in the longer term. So in this situation, clinicians, the doctors, increasingly determine what are the activities that have to take place. Right? And here, basically, you can do central planning, because you know in advance what will take place with the patient. And here, you have to give more autonomy to the doctors, and central planning is not possible. Okay? In the short term, we look at the variability of one step in the care pathway. So, for example, one appointment or one surgery. So, a cataract surgery is 51 minutes plus or minus 1 minute. It's very good to predict, I was told. I'm not a specialist. But a total hip replacement is less easy to predict the duration. So what does that mean? So the harder it becomes to predict the duration of these appointments, the more flexibility you need in your scheduling, right? The more buffers you need to deal with this variability. Typically, you see a target utilization or target performance indicator for all the patients, but it doesn't make any sense. So for the patients where it is hard to predict the duration, you should expect a lower utilization because you have to have more buffers in your schedule to deal with the effects of the variability. Robust planning becomes very important here, and you have to try to reduce this variability and optimize flexibility. Whereas here, basically everything is deterministic, and you can optimize things nicely mathematically. So you can position your case mix, your patient types in this framework, and based on this positioning, you may make such kinds of decisions where you say, okay, here you can do central planning, but here actually the doctors do the planning. So it may be a good idea to split your capacity accordingly. Okay, that reduces the complexity and also gives the autonomy to the appropriate parties. You shouldn't let the doctors plan here because typically doctors are not very good at that. But here it is very necessary to do that. Okay? So it's not clever to mix these things up. So such kinds of analysis you can easily do with dashboard applications and business analytics, business intelligence type software. Essential to optimize planning is all kinds of tools. Computer simulation tools, this is a simulation of an ED, this is a Harmony, is a personnel rostering software, such kind of Gantt charts for planning appointments. Visualizing the solutions really convinces doctors that this new way of working actually works. Okay, so doctors, they are educated in evidence-based medicine, and they also operate and manage their business in an evidence-based way. So they will only copy our ideas if they are convinced that it will work. So with a computer simulation or a mathematical model, we can demonstrate that a new way of operating the business actually works. That really helps to convince them. Visualization leads to understanding, understanding leads to commitment, commitment eventually leads to implementation. I'm going to skip this. So 4 essential elements. Performance measurement, this is where it basically starts. So when you fill in the planning and control framework of a hospital, your point of departure is, so what are the performance indicators that this hospital wants to optimize, and what are the targets that the hospital strives for? And this gives you an idea how to fill in the planning and control. Integral planning and control, so the care pathway as a whole, all the hierarchical levels, not just operational and strategic, but also the tactical level, and all the managerial areas connected. IT instruments are essential. And also the embedding in the organization of logistics is very essential. Typically you see the knowledge very dispersed over a hospital. There's a guy at the operating room department who knows a lot about logistics. There's a guy in the lab and there's a guy in radiology, but you need to get these guys together if you want to integrally optimize care pathways, and also get them together with the IT people. So we've done research many other topics I could talk about the whole day. I don't have time for it, so I would like to keep it with this. Thank you for your attention.